series of IAAS. That's the International Association for Ambulatory Surgery for you. And this time we have an excellent speakers with two very distinguished moderators. I have the privilege of introducing to you Dr. Girish Joshi. He is an anesthesiologist from Dallas, and he represents Samba in the IAAS. The other distinguished moderator is Xavier Falières. He is from the Netherlands, the president of the Dutch Association of Ambulatory Surgery, and he also is an anesthesiologist. Over to you both.
Thank you, Naresh. It's an honor to be part of this webinar program. Let's get started. I first want to introduce Professor Tae Yop Kim. He is a professor of anesthesiology at the Konkuk University School of Medicine. He's also the current Korean president of the Korean Association of Patient Safety and past president of the Korean Society of Anesthesiologists. He's going to speak to us on intraoperative use of processed EEG in ambulatory setting. Thank you, Professor. Yes, let's get started. Thank you.
Okay, thank you. Sorry, I'm Tae Yop Kim, Konkuk University, South Korea. My talk is use of a Processed-EEG in ambulatory setting. These are my disclosure. I'm the president of Asianese Forum, a scientific group supported by Medtronic, the company producing a bispectral index. During 15-minute talk, I briefly talk about the limitations of classical number-based process monitoring, the need for band-specific management strategy using dense spectral analysis, especially for maintaining slow delta and alpha band dominance, and for avoiding burst suppression. Let's start the limitation of our long-time strategy, the number-based process in monitoring. The left-hand side is multiple raw EEG tracings. Even the small pieces of the conventional EEG tracings can be classified into 5 band-specific subtypes, high-frequency gamma and beta band, and alpha band ranging 8 to 12 Hz, and low-frequency zeta and delta band ranging 0 to 4 Hz. Different power distribution among these subtypes partly reflects the depth of sedation and alertness. However, it may be very difficult to apply conventional EEG monitoring in sedation patients for everyday anesthesia practice. These are 4 different process EEG monitoring devices currently used in the Korean market. All these process EEG monitoring were developed to make EEG monitoring much easier in everyday practice. I also wonder how many surgeons watching this program have been interested in the monitor's role. I guess that most of the surgeons are not much interested in process EEG monitor, or do not have a chance to see or focus on the monitoring screen, probably due to their ignorance or the monitor's location in the operation theater. However, as shown in this photo taken from Korean media in a report regarding the use of processed EEG in veterinary clinics in Korea, some of veterinary surgeons are now using processed EEG to precisely measure the depth of dog's anesthesia and adjust the dosage of anesthetics. As in conventional EEG, deepening of sedation increases the power of low-frequency components and reduces the power of high-frequency components in the frontal EEG wave from processed EEG monitor. If the sedation level is too deep, we can see repetition of burst and suppression as a complex. All processed EEG monitors generate an index numbers from analysis of the raw frontal EEG wave pattern during proper sedation. They are using various algorithms to generate numbers, but the algorithm-based concepts are very similar. More low-frequency EEG power generates lower index values. Conversely, more high-frequency EEG power generates higher index values. Sorry. The generated index values, mostly ranging from 0 to 100, should be correlated with the anesthetic effect on brain electrical activity. All vendors suggested that target numbers of their process EEG monitor, which can be used as a surrogate for titrating dosage of anesthetics. In most cases, 40 to 60 in this, 25 to 50 in sedation maximum. Initially, we used this target index to prevent intraoperative awareness. Now we are using them to titrate the anesthetics to avoid anesthetic overdosing and oversedation, the risk factors for intraoperative hypertension, organ ischemia, delayed emergence, and post-delirium. Of course, too deep sedation compromises the overall ambulatory process by delaying the speed of recovery or increasing the risk of posterior delirium. However, many limitations compromise the reliability of the number-based strategy. One is the mismatch between the index and the real depth of a patient's sedation. The numbers cannot differentiate among various levels of consciousness and unconsciousness. The same indices across different patients showed markedly different sedation statuses, and the similar sedation level showed very different indexes. In a study, green-colored burst suppression tracings in the blue-colored BIS value showed a significant mismatch in this slide. Burst suppression, which is suggesting too deep sedation status, was frequently associated with BIS values ranging 40 to 60, which is suggesting an apparently adequate sedation depth. This case is taken from the site of Dr. Nunes and social media, LinkedIn, showed that Processed-EEG suppression rate was 27% at BIS value 48, 41% at BIS value 36. Even burst suppression rate was 5% at BIS index value greater than 70. Similar mismatches were observed in the use of entropy, another Processed-EEG monitor made by GE, and the incidence of mismatch was increased, especially in older patients. Furthermore, adding anesthetics as adjuvant, such as ketamine, greatly affect index values. As shown in this case of Dr. Herrera, adding ketamine increases sedation depth. However, the index is pedagogically increased by the ketamine's effect, which increases high-frequency beta band power. We have to keep in mind that most algorithms for generating indices from Processed-EEG were developed based on proper sedation. Another challenging situation is higher BIS values during the use of recommended doses of remimazolam. Even in quite well-sedated patients using remimazolam, BIS values are usually greater than 60. Sometimes it's difficult, impossible to achieve BIS value less than 60. However, these patients with higher BIS value were evaluated as adequately sedated when we apply other sedation scale. If we give more remimazolam or other sedatives due to higher BIS value, it would lead to too deep sedation status. Increased high-frequency EMG activity in the absence of or reduced neuromuscular blocking activity is quite common in recovery period, can increase BIS easily and compromise the reliability of index-based processes monitoring. Other factors complicating the reliability of the index-based processes monitoring include 3 unexpected behaviors of Processed-EEG waves at intense pain with insufficient analgesia. Intense pain increased cortical activity and increased beta band power, inducing an erroneous increase in the index value. This is called beta arousal. In this situation, the high index value leads us to give more sedatives instead of giving more analgesics. Intense pain also increases low-frequency delta power and reduce index values. Sometimes it generates too low index values even in the absence of burst suppression. In this situation, called delta arousal, although patients need more analgesics, we have to reduce dosage of sedatives. Intense pain also affects salavo-cortical communication, changing the salavo-cortical connection from ideal mode to an operation mode. This is called alpha dropout. Also affect index values by changing the relative power of other bands delta, zeta, beta, gamma. All unexpected behaviors compromise the reliability of index value-based process monitoring. The index number in Processed-EEG is not linearly related to the changes in anesthetic dosages and the complex brain sedation status in various anesthetic cases. For ensuring both anesthesia optimization and safety in using Processed-EEG monitoring, a strategy that rejects the use of index numbers and prefers focusing on the raw EEG waves and their spectrogram has been introduced. Yes, it is time to implement dense spectral array DSA PE for Processed-EEG monitoring. DSA is one of the various types of spectrogram, a time frequency representation of the EEG. One axis present time, the other frequency, and the visual intensity represent the spectral power. This is a schema of DSA showing the real-time changes in the band-specific power of frontal EEG waves. The left-hand side vertical axis indicates the frequency of EEG waves, and the right-hand side red-green color coding represents the power of the corresponding EEG band. If we use bilateral POA sensors, upper and bottom dual displays indicate DSA patterns from both sides, left and right side frontal lobes. The DSA display can be enabled by changing the display mode on some older BIS models. Other Processed-EEG monitors, such as Connox and Satellite, can provide DSA monitoring capability. Patients use adequate intraoperative sedation and analgesia shows a typical slow delta and alpha dominant BIS pattern. And no burst suppression is associated in the EEG wave tracings. Therefore, instead of targeting a certain index value, anesthetic titration should focus on maintenance of delta and alpha band dominance in DSA and avoidance of burst suppression. This is for achieving optimal intraoperative sedation and analgesia. Another reason for focusing on alpha band power is that strong alpha band power is a surrogate marker for sufficient analgesia. This case of a video assisted thoracic surgery, alpha dropout and alpha weakening were repeatedly developed at tracheal intubation, thoracotomy incision, and reduction of brain fentanyl dosages. Meanwhile, as in this case, insufficient intraoperative analgesia induces evolution of alpha band power as well as the peaky increase of delta power. Our case shows that abolition of alpha band power and simultaneous decrease of BIS values had repeated reduction of brain fentanyl TCA dosage from 8 to 5 nano/ml. Fortunately, in most cases, if we increase the analgesic dosage, as in the incremental dosage of brain fentanyl TCI, we could see the restoration of abolished alpha power. Of course, we have to make sure whether our current regimens are adequate to provide for sufficient analgesia across varying levels of surgical pain. And consider the synergistic interaction of the sedative opioid combinations. Another value of supporting PSA is monitor alpha band power and burst suppression is as an indicator of patients' vulnerability to POCD delirium and worse possible outcome, alpha band power and burst suppression can be utilized. Low alpha band power after anesthesia induction and intra-hour period show the higher incidence of post-op delirium and POCD. And POCD patients had a reduced alpha band power before and during the operation. Patients with relatively weaker alpha power show the higher vulnerability to developing post-op delirium. Intraoperative burst suppression is also a predictor of a higher incidence of POCD and post-op delirium. While avoiding interrupted burst suppression, alternative expressions of repeated burst and suppression in low EEG can be displayed in the DSA tracings. Therefore, we have to monitoring these shapes in DSA monitoring is necessary. Burst suppression is displayed as a vertical dark line in DSA monitoring. Considering the burst suppression is usually transient and instantaneous, in a certain case, DSA monitoring can be the only way enabling the detection of current and prior association burst suppression. We must titrate the sedative dosage by gradually escalating it to achieve enhanced alpha power and avoid burst suppression. Especially in vulnerable patients, even quite a small dose of propofol can induce burst suppression and reduce alpha band power. Therefore, DSA-guided propofol dosage reduction may be required for these patients. Then, is it always easy or possible to monitor alpha band power in every anesthesia cases? Not always. We have to consider its limitations, including its age-related variations. The alpha band dominance is absent at birth and is not apparent until 5 or 6 months old. Furthermore, alpha power decreases with age. It becomes weaker with age and cannot be assessed at age greater than 70 years. However, we can adjust the color powder scale of EEG band to improve visualization of alpha band power in a certain type of Processed-EEG monitors. This adjustment would enhance individualized anesthetic management, especially in older and frail patients with reduced alpha band power. However, if there is a weak alpha band power in old age patients, it is still difficult to differentiate age-induced abolition, the need for more analgesics, the patient's own risk related to developing POCD, or a too high dosage of sedatives. Furthermore, agent-specific DSA patterns also complicate its interpretation. How about DSA monitoring during patients awakening after surgery? During emergence, alpha power decreases, beta-gamma dominant returns, and delta band phase. All these generate the typical opening of crocodile upper jaw pattern. If your patient doesn't show upper jaw opening upon awakening after surgery, you may have to suspect the prolonged status with deep sedation, deep awakening, or patient's own atypical recovery due to age-related vulnerability to anesthetic agent. Do you need more information? If you go to social network, such as LinkedIn, and connect with many EEG experts, you can get very up-to-date and practical information regarding the pulse of Processed-EEG monitoring. This is an example. The information on delta alpha phase amplitude coupling was posted by Dr. Federico on LinkedIn. This is a summary of my talk. The number index does not well reflect the patient's range status. Now is the time to adopt a DSA-based strategy and band-stress Processed-EEG monitoring. This is shifting from threshold-based monitoring to pattern-based monitoring, maintaining interrupted slow delta and alpha dominance, and avoiding burst suppression can provide improved titration, avoidance of excessive anesthesia, identification of vulnerable brain status, and possible reduction in complications such as positive delirium and awareness even in the ambulatory setting. Thank you very much for your attention.
Thank you, Professor Kim. We'll do the question answers at the end of our panel. Xavier, you're muted. Xavier, you're muted.
Turn on your microphone.
Yeah, sorry, I was muted. Sorry, I don't know. Okay. Yeah, so my pleasure to introduce Suraphong from Losomradee, Associate Professor Anesthesia in Chiang Mai, Thailand, international speaker and educator, and also the representative of for Asia at the Council for the WFSI.
Hello everyone,
He is
I'm
very
Tae Yop Kim
involved
from Konkuk
developing.
University. It's great honor.
Yeah. So he's involved developing ambulatory surgery in Thailand and Southeast Asia. And his presentation, his lecture will be about hemodynamic monitoring during general anesthesia in ambulatory surgery.
I'm going to play it. Is it okay?
Good evening from Asia. My talk is about the hemodynamic monitoring during general anesthesia in ambulatory surgery visits. We used to think that in ambulatory surgery it may be normal surgery and some simple surgery that don't need any sophisticated or advanced hemodynamics monitors. And I don't have anything to disclose about this topic. And this is the picture that we have a look every day during surgery. But normally we have the heart rate, blood pressure. But in some case, for example, some moderate to high risk surgery, we need to do some develop for the ambulatory surgery. Sometimes we need some arterial line or some non-invasive hemodynamics monitor. And every anesthesiologist that you work with, as you may be a surgeon, work with anesthesiologists. Normally, when the blood pressure is going up, anesthesiologists sometimes they used to believe that we have to control hemodynamics, but actually no. At the beginnings of doing that is we have to do anesthesia optimization first, and then we go to the next step of the hemodynamics. For example, there's a lot of reasons why the blood pressure is going up. For example, sometimes it's maybe from the light anesthesia, or the patient have hypertension or elderly. And some patients they have some kind of shock, anaphylactic, or something that vasodilate during that, not only anesthesia. That's why every time we have a look like that, we try to maintain blood pressure about the mean arterial pressure more than 65 millimeters mercury all the time. Why? Because normally our body try to maintain our MAP more than 65 all the time. For example, if we have something happen during operation, like low seismic vascular resistance, the body try to compensate it by increase cardiac output to maintain normal blood pressure. That's why we recommend to use MAP more than 65 all the time. In another angle, instead of SVR is fall down, it may be from cardiac output is fall down. The cardiac output is fall down is normally happen in general surgery. For example, we have a lot of blood loss or some contractility is lower because cardiac output is from stroke volume and heart rate. And stroke volume is come from two factors, from contractility and from Frank Starling mechanism from fluid responsiveness. And the body tries to compensate it by increase seismic vascular resistance to maintain vascular tone, and we have to think about the blood viscosity all the time. That's why we try to maintain MAP more than 65 during the operation, no matter its fluid responsiveness or the low vascular resistance. And the trend of fluid resuscitation during operation will change from conventional approach to restrictive approach, and then right now we're going to the goal-directed fluid therapy by optimizing, maximizing the Frank Starling mechanism at the top of the curve of the heart chamber. And goal-directed therapy, everyone know that is part of the IAAS program, enhanced recovery after surgery. During operation, anesthesiologists we do the early mobilizations and patient warming, cold therapy, and we optimize the fluid and also control the pain with opioid-free analgesia as well, and prevent PONV. And we know that maintaining hydration during fasting is very important, and we need some minimally invasive surgical technique to reduce blood loss, and we need to monitor the fluid status very well. That is very good for post-operative, especially for the PONV. And the trend of monitor fluid status during operation. Right now we move from static parameter like central venous pressure, which is we need invasive one. Right now we move to the dynamic one. The dynamic one can be from stroke volume variations, pulse pressure variations, or the pulse variability index, which may be from invasive, less invasive, or non-invasive. This is from heart-lung interaction. Normally when we breathe in and breathe out, when we breathe in, breathe out, we change the intrathoracic pressure, and it will change the preload status, and this one will increase and decrease the pulse pressure. That's called pulse pressure variations or stroke volume variation. As you can see from this one, SVV PPV can come from minimal invasive blood pressure or from arterial line. But the PVI, the pulse variability index, we can use this from totally non-invasive, from the pulse oximeter. That's why we can use it for the ambulatory surgery. This is example that before and after fluid challenge test, and the SVV PVI also change in the trend like this. We can use it as a trend. For example, in the beginnings of the operation, we may generate some vasodilate, and we think that this is fluid responsiveness. But actually, we have to think that this is physiology of vasodilate, maybe from something like too much pain control or some spinal block like that. Instead of just give the fluid, maybe we need some vasopressor like that to make the patient back to normal physiology. And before we believe that this is a physical change of the fluid non-responsiveness, we have to make sure that during that general surgery, general anesthesia, the tidal volume should be more than 8 milliliters per kilogram to make sure that the data is reliable, control ventilation, and during closed chest surgery. And if we have high number, it means fluid responsiveness. Before we believe that, we have to make sure that this is normal or physiologic PEEP and no cardiac arrhythmia. How can we know that this is like need fluid or need vasopressor? For example, if we have the PPV and SVV parameter in the same monitor, we need to use that. If the PPV is more than SVV, this is fluid responsiveness. But if PPV is lower than SVV, this is called vasopressurization syndrome. This means that if we give fluid, it doesn't matter, nothing happens. We need vasopressor to help the patient. For example, like this, you can see that if PPV is lower than SVV, this is vasopressurization syndrome. We need vasopressor, not only the giving fluid, but we need some like pain control. We need some surgical stimulation or something that vasoconstrictor, like epinephrine. And the stroke volume can come from what? Can come from the thing that we measure the flow of the river, flow of the waterfalls. It can come from swan gans, which is too much invasive, too much for the ambulatory surgery. Echocardiography may be too much, but for arterial pulse control kind of output may be optimum for the minimal invasive surgery or minimal invasive monitor for the APCO. But this can come from arterial pulse control, right? But we can use it from totally non-invasive cardiac output monitor like that. The cardiac output is from part of calculation of the oxygen delivery. That's why it's important. For example, at the beginning, if we have low hemoglobin, low oxygenation, and low contractility, but we can improve. When we improve the oxygenation, we can improve only this part. But if we improve contractility, we have advanced hemodynamic monitor from totally non-invasive, we can calculate for where we are for the oxygen delivery. For example, this one, we need hemoglobin. That's why we need non-invasive cardiac monitor in some advanced case. Because right now ambulatory surgery is developed for more and more advanced surgery that they can do day case surgery as well. To summarize, mean that in low risk surgery and low SA classification, there's no benefit from the co-directed therapy, especially for the ambulatory surgery. But in some intermediate risk surgery or SA classifications, high SA classifications, we may need the minimal invasive monitor or non-invasive hemodynamic monitor. And we all know that co-directed therapy, when guided by advanced hemodynamic monitor, does not show added benefit, particularly in outpatient surgery that I mentioned. But now the trend of outpatient surgery is more and more invasive one. If we would like to do that, we can use totally non-invasive advanced hemodynamic monitor to guide. For example, if we have ECG and pulse oximeter like that, this is very simple one. For example, we can have kind of output from many technology like pulse control or the volume clamp technology, but this I will show the example of the ECG and oxygen saturations. You can see the delay time is called pulse wave transit time. The pulse wave transit time is related to from the peak to the uprising of aortic root. This is contractility. From uprising aortic root to the uprising of the radial artery. This is related to the blood pressure. From uprising of the radial artery to pulse oximeter, this is related to SVR. That's why if we relate from the ECG to pulse oximetry, this is related to stroke volume. If the pulse wave transit time is short, it means stroke volume is increased. That's why we can calculate for stroke volume. This is called estimated continuous cardiac output, totally non-invasive. This is just example. For example, if I use estimated continuous cardiac output for totally non-invasive, can we use it to guide? Yes, we can use for the trend change. For the change before after intervention or change before and after fluid loading and titration of anesthesia. This is, for example, one of my studies show that I relate the estimated continuous cardiac output to the estimated continuous cardiac output of the flow track compared to the totally non-invasive one. It in the same trend that change. And sometimes we do the leg elevation because we don't have to do the real fluid resuscitation. We can do leg elevation during operation, especially ambulatory surgery. When we do leg elevation, the Frank Starling mechanism is changed. No matter we use propofol or sevoflurane, it still responds very well. And we can do the fluid challenge test. For example, 200 amount of fluid in 5 to 10 minutes and change of the stroke volume more than 10% or not. The green one represents the fluid responsiveness. The red one is fluid non-responsiveness. For example, this one, at the beginning 30, and I load the fluid, and then 48. This is more than 10%, right? So this is fluid responsiveness. I load more until this is 10%, ready to stop. And then from 80 to 84, this is fluid non-responsiveness. Cannot give fluid anymore. This is that why we use stroke volume or estimated stroke volume from non-invasive monitor to guide. For example, this one, fluid challenge with estimated stroke volume variation from totally non-invasive hemodynamic monitor, still the same patterns of the invasive monitor. This is example of the monitor that I use during abdominal surgery. The relationship is correlate very well with the invasive one and the change in trend, same trend after fluid challenge test. This is the same pattern of fluid challenge test. Another parameter that I would like to show that this is appropriate for the ambulatory surgery is called perfusion index. The perfusion index is from technologies of pulse oximeter. That is very simple and totally non-invasive from simple pulse oximeter, and it happen and show every monitor. We can use it for the change. For example, the pulse oximeter like that is from the percent of AC, the arterial pulse, compared to the total tissue that calculate statics compared to the AC currents. AC divided by DC is a perfusion index. Normally, in adult, it should be more than 1%. In pediatric, it should be more than 0.7%. Do you think which finger is the best to monitor perfusion index? From my study, it's the ring finger. The ring finger is have highest perfusion index. So if we monitor pulse oximeter at the ring finger, we can monitor for guide the cardiac output and automatic activity. Because PI is related very well with cardiac output, but it's opposite, inversely related with the vascular tone. That's why during we monitor for cardiac output, we have to think that we should not change autonomic response. Do not change the vessel pressure status. Do not change the vasodilator status. And we can use relate very well with the vasopressia or hypovolemia or cardiac failure. And then finally we go for microcirculation. After we optimize macro circulation, we go for micro circulation. For example, right now we can have the non-invasive monitor like the cerebral oxygen saturation. From the cerebral oxygen saturation, normally if we attach it from the forehead, it's totally non-invasive. And in the beginning, if the number is 80 or the number is 60, we try to maintain 20% of the baseline. If we don't know baseline, we try to maintain more than 50 all the time. This is, for example, at the beginning, before starting surgery, we monitor baseline oxygenation of the brain, and we can use this to guide the hemodynamics very well. This is part of the enhanced recovery after surgery by using the goal-directed therapy for safety and quality. I thank you very much for your attention.
Right. Thank you again. So, David, you want to introduce our next speaker? We'll do the question answers at the end. Thank you.
Our next speaker is René van der Voort. René is anesthesia nurse and sedation specialist in the Netherlands. He is working in the same hospital as I'm doing in Ambulatory hospital in Dordrecht, south of the Netherlands. Sedation specialists, few countries in the world, they have sedation specialists. They are doing wonderful work, and we see every year an expansion in the number of sedation specialists that we have and all what they are doing. It's not anymore simple colonoscopy, but it's EBUS, small gynecology, and so René is going to present us how to implement sedation in a hospital.
My name is René van der Voort from the Albert Schweitzer Hospital in Dordrecht, the Netherlands. I'm one of the 7 sedation specialists in our hospital, and I'm going to give you a practical presentation about some of our procedures that we do in our hospital. So the most sedations we perform are performed in our main location, which is situated in the city of Dordrecht. And it's called Dordwijk, and there we do the most of our sedation. But let's start with the explanation of what a sedation practitioner actually is. Well, it's a nurse anesthetist who followed advanced training to safely and effectively administer moderate and deep procedural sedation analgesia, or PSA, to patients undergoing diagnostic or therapeutic procedures. All that without needing an anesthesiologist on site. And especially this last sentence causes quite some discussion every time. Of course, the anesthesiologist is inside the building, and when we would ever need him or her, we can call them, and they are roughly. We perform the sedations by ourselves. When we do the preoperative screening, we also do it by ourselves, but we always have to get approval from the anesthesiologist. And when that approval is finalized, then we can go perform the sedations on our own, almost everywhere in the hospital, as long as there's a power outlet and an oxygen outlet. So we're doing it for quite some years, 10 exactly. We recently celebrated our 10-year anniversary. And as you can see, we started doing more procedures every year. And the last few years were almost steady at more or less 2,000 procedures per year. So these are a few examples of the most common procedures where we perform PSA. Gynecology, gastroenterology, and cardiology are our biggest departments, but we do a lot more than we only show here. For instance, MRI scans for people with claustrophobia, PET scans, and a lot of other procedures not so common. These are the most common ones. And the more high-risk procedures are found in, of course, the cardiology department, but also the pulmonary function and the ERCP and actually the gastroscopy as well, because these are procedures that have a shared airway. So that's the reason I would like to talk about these two procedures, the ERCP and the EBUS. So let's start with the endoscopic retrograde cholangiopancreatography. We performed that in the radiology department. They have a very nice updated room since a few years. And here you can see the setup of our table where the patient is lying. You can see 3 blue pillows. These are prone pillows. So from the right to the left, we have our headrest. We have a thorax cushion and a pelvis cushion, I think. So the patient can lie down in a prone position and making room for the abdomen to breathe freely. Since we started using these pillows, our sedations are much more stable in terms of breathing and oxygenation of the patient. Here you can see the patient lying down a few moments before we're going to start, talking to our gastroenterologist who is performing the ERCP. And you can also see that there's a nasal high flow air device inside the nostrils of the patient. So the head is tilted to the right. Most patients don't complain about this position. It's not comfortable, but it's not the worst either. And here you can see my colleague. His name is Falières, and he's performing the sedation and assisting the gastroenterologist by inserting the scope. So this is mid-procedure. The nurses of the gastroenterology department assist the gastroenterologist with the ERCP procedure. And in the back, you can see our trolley, which has everything we need to perform proper sedation and to monitor the patient. Here's a view from the other side. So we started doing the ESRP almost immediately after we started doing sedation in our hospital, so 10 years ago. And before that, they had only midazolam fentanyl. Mid-2016, we have the transition from the midazolam fentanyl to the propofol-based PSA that we perform. And they soon found out that the propofol was the more preferred way to go. There was a higher cannulation rate, less complications, less re-RSPs. So nowadays we only perform ESRPs with propofol, no more midazolam fentanyl by the gastroenterologist himself. In 2019, we started using those prone pillows, those blue pillows you saw earlier. And in 2022, we had the nasal high flow device. So we were evolving and making the procedure better every so years. So in 2022, we started asking ourselves, why are we letting every patient staying for the night? Because the patient is undergoing the procedure in a good manner. Maybe we can send them home the same day. So we made some adjustments in starting times and other adjustments. And even after that, 15 months later, we reviewed our ESRPs, and we had 174 ESRPs that were admitted on the same day of the procedure. And of those patients, more than 60% of those patients went home the same day. So that is a major improvement instead of letting them stay for the night. A few, 25%, needed extended recovery, meaning at least one night, and 14% needed to stay 2 nights or more. But I think this is a great way of showing how ambulatory settings can spare you the costly beds we use at night. So this is a trolley you saw earlier. It's electrified, so with the push of the button, we can drive it throughout the hospital, and literally everywhere where there's a power outlet and an oxygen outlet, we can perform sedation. So we literally almost go everywhere if needed to perform our sedation. What you can see, we have our monitor on the right-hand side with the PDMS, the patient document system. On the top, we have a little smaller monitor for the parameters like the blood pressure, saturation. On the left, we have 2 spuitpompen for the syringes and the TCI model. And on the bottom left, you can see our nasal high flow device. And hiding after that is our suction unit for the sucking out of extra saliva and that sort of stuff. And the drawers, of course, with all the syringes and medication we need to perform the sedation. And also on the top left, not clearly to see, but we have a ambulatory balloon, so we can perform manual breathing if ever needed, but all our patients stay breathing throughout the entire procedure. That's the beauty of the PSA, the procedural sedation analgesia. So now for the endobronchial ultrasound, or the EBUS bronchoscopy, also a shared airway, and even more so than with an ESRP, because the scope is literally going through the vocal cords. Major prickle for the patient, so we need proper sedation for this procedure. Now, I was planning to show you a video, but that would mean I had many gigabytes to upload, so I only left it at 2 still frames where you can see quite a lot. You can see me in the light blue inserting the nasal high flow device, and on the left side we have our nurses preparing the local anesthetics to give to the patients. So what we do with this procedure, we give sedations in two ways. First, we start with as we like to call roesje. So the patient is still awake, is still responsive, and can follow commands because they have to open their mouth, stick out their tongue, sit upright, and then we can spray the local anesthetics in the mouth and later on deep in the throat to anesthetize the entire throat and mouth area, which is very much needed because the vocal cords are very responsive to stimuli. So with only sedation, we wouldn't get there. After that, we're gonna put the patient flat on their back, and I'm gonna start the sedation with the propofol. So first, for the first part, we only use a little bit of midazolam and a little bit of propofol on a TCI model like 0.5. And after the local anesthetics are put in the mouth, we start up the sedation. Behind the bed, there, not looking this way, is the pulmonary doctor performing the EBUS, and we have another nurse assisting the doctor. So this is mid-procedure. If I would show the movie, the nice thing would be I have sped it up, and you can see everybody moving around, but no, except for one, and that is the patient. And I thought it was a nice thing to show that the patient is lying perfectly still, almost unresponsive, sometimes a little bit of grabbing with the hands, but totally not aware of what is being performed by the pulmonary doctor. You can see me on the right hand side. I have time to even answer some emails. And of course, the monitor is beeping, so I know the patient is breathing properly. So this is an overview of the same procedure that took about 40 minutes in total, actual procedure time of 30 minutes. And you can see on the top, there are some blue dots. Those are the saturation of the patient. And in the first part, they're a little bit scribbly, right in front of the, I think I use my mouse. Like here, you can see the saturation is not a straight line. And as soon as I turn on the nasal high flow device, the saturation hits the roof. In other words, 100%, and it doesn't leave the roof. So the nasal high flows device is a real game changer for us, making it more safe to perform the procedure. We can go a little bit deeper with the patient still breathing, but not declining in its saturation. Now as well, you can see the blood pressure is pretty stable. And I have another zoomed in overview of the medication we give. So we start with a little bit of midazolam and the propofol on a very low rate, 0.5, 0.7 maybe. And after the local anesthetics are given, we're gonna up the propofol to 1.5, maybe 3, whichever is necessary. And after the patient is fallen asleep, we give them a little bit of esketamine and lidocaine, also to prevent the cough prickle, as well as the insertion of the propofol that can hurt a little bit in the veins. So esketamine, higher propofol, and sometimes when the patient is a little uncomfortable, we give small doses of alfentanil. And in this case, the blood pressure was a little bit going down. So one time inotropic in the form of phenylephrine, and that's the whole procedure. So this is my last slide. I hope you enjoyed seeing some of the practical sides of our procedures in our hospital.
That was the last presentation.
Okay. I guess we only have Dr. Kim here for Q&A. So, Dr. Kim, I have a practical question for you. I understand that Processed-EEG analysis of the EEG waveform is the next wave, and that's the way to go. And using the numbers is inappropriate, according to you. Am I correct in understanding that?
Yeah, great question. I think that I totally agree on your opinion, and I think you correctly understood. And to my memories, you gave the same question. I was quite conservative to give the answer, but I can be straightforward in terms of saying no, because even during very short-term period, we got another evidences supporting the use of the benefit of using dense spectral analysis, band-specific analysis, and some harmful, some wrong practice relying on the just number. And as we know, at the very beginning, nobody believed in this value, but we became familiar with that values, and even that period, some of scientists insisted that 40 to 60 is too deep, especially using volatile anesthetics in opioid. Some of our scientists insist that optimal values around 65, but we never, follow their opinion. But the reason was, we just rely on the number, the time, and the values recommended by the vendors, the manufacturer. And it's another news that there will be new satellite monitors for the pediatric use. They will not include the number in the monitor. Why? Because the index number can make some confusion and lead to something malpractice and wrong practice in terms of avoiding too deep sedation, too deep anesthesia. As I mentioned before, we simply regard that awareness is problematic, but now giving too much and over sedation may be much more harmful for the patients and more critical in terms of producing aggravating patient's outcome. So we have to discard our strategy, 100% rely on the index value. Another thing is, in the United States, mostly use the balanced one, but some of anesthesiologists prefer using ketamine or other adjuvant anesthetics. In such case, that just adding the another type of sedatives can compromise the reliability of index values, as seen in my slide. Okay.
Thank you. So I'm just going to recap. Don't use numbers anymore. You're still a believer of using these Processed-EEG monitors, but using the analysis from the monitors of the waveform rather than the number. So according to you, for somebody who is not used to understanding how to analyze these waveforms, a quick one, and I know you mentioned it, I just want to recap, is by you, as far as you're concerned, what would you consider as deep anesthesia? When is it burst suppression or any other indicator? When would you say a patient is deep, too deep?
Yeah, as shown in my presentation, even in the very well, good values of index value in 40 to 60, patients can be associated too deep sedation with burst suppression. And
so forget the numbers now, just from analysis of the waveform. how would you say, oh, this patient is too deep? But for a naive person
right.
to starting off with analysis.
Yeah. Probably, I can say that we cannot 1% focusing on the screen of the Processed-EEG, but we can see the EEG waveform at first. And if there is, the vertical black line in the previous, display, the DSA, produced display the previous band pattern, we can see that. And especially for the patients is very vulnerable to the birth suppression. I mean, too old and already had some previous comorbidity in terms of producing birth suppression. Even in cardiac cases of compromised blood supply, and even patients that's exposed to the very low temperature, that condition is very easy to be associated with birth suppression. Such as we have to be very concerned in the current, tracing and the DSA, even in the EEG patterns. I think that if we can, study, spend a little time to be concerned about EEG pattern, it can easy to see what's going on and what is birth suppression pattern.
Yeah, but now you understand where I'm coming from. There are so many other factors that can cause birth suppression. And on one hand, we say don't use the numbers, which is appropriate.
Yep.
Other hand, we say use the analysis of the waveform. That's also okay, but there is still no guidance for somebody who occasionally uses these monitors as to what would be the right waveform look or visualization of waveform, which would say, okay, this patient's too deep. Obviously, we want to avoid deep anesthesia. And there are so many other factors, which is what's causing resistance in adopting this waveform analysis.
Yeah. I think that even my colleagues, although I'm using, spend much time, more time to see the EEG waveform, but basically we didn't have any, education and in spite of the people, who insist in the importance of EEG pattern and the DSA. But it's quite good news. I realized that every national society is starting the Processed-EEG workshop, and probably attendees are usually young doctors, but there are great spread of knowledge and insisting the importance of Processed-EEG monitoring and the wise ways to use that expensive monitor. Even in Korea, although we have a long history of using Processed-EEG monitoring and getting reimbursement, but we stick in the just number. But now we are a lot of echoes to to inspire the people to spend more time and see the Processed-EEG monitoring of DSA and the EEG waveform rather than the index. But unfortunately, even our EMR record, just a number is conveying to the EMR record is interfacing. Still, there are a lot of hurdles to to be utilized by the people. Probably more effort and more research, and probably in the future, it's something much easier pattern of something to integrate it into easily use that parameters in our practice.
Thank you. Maybe at our next IAAS meeting, we should have a workshop on how to analyze EEG monitoring. Any other questions from the audience?
Great.
Okay.
So this brings us to the end of the third the webinar, and I thank the moderators and the speakers for their contribution. This video has been recorded. This whole program has been recorded. I will be editing it, and it will be available for everyone to see permanently on the IAAS YouTube channel. The next, that is the fourth webinar, will be on the 1st of August. Details will be circulated most probably by tomorrow or the day after. And I wish you all good night from India. Bye-bye.
Thank you, Naresh, and
Good night from the
we will
Netherlands.
continue our
Bye-bye.
discussion.